This is a podcast that I've been asked to make by the European Lupus Society, or SLERO. My name is Anisur Rahman and I work at University College London in the United Kingdom. The subject that I've been asked to talk about today is management of patients with SLE and positive antiphospholipid antibodies. And I'm going to divide this into a number of parts. First of all, I'm going to talk about patients who have SLE and true antiphospholipid syndrome. That means patients who fulfill the criteria for antiphospholipid syndrome and need to be treated as such. Now, it's important to remember that the treatment of these people is just the same as any people with antiphospholipid syndrome. The fact that they have lupus as well doesn't alter the management. And after that, I'm going to talk about patients with SLE who have been found to have antiphospholipid antibodies but don't have the syndrome. So let's start by talking about antiphospholipid antibodies. These antibodies are present in about 5% of the healthy population and can be found in between 7 and 15% of patients with SLE. However, not all patients with the antibodies develop the syndrome itself. In order to be defined as having antiphospholipid syndrome, one must have persistently positive antiphospholipid antibodies and also have clinical features such as vascular thrombosis or pregnancy loss. The pregnancy loss, according to the definition, is very clearly defined. It is required to have either several consecutive first trimester miscarriages or one late pregnancy loss, and there shouldn't be any other reason for that pregnancy loss. Now, as for the antiphospholipid antibodies themselves, there are 3 tests typically used clinically: the anticardiolipin ELISA, the anti-beta-2 glycoprotein 1 ELISA, and the lupus anticoagulant test. And it's important to know that an individual patient can be positive in either 1 or 2 or all 3 of these tests. And people who are positive in all 3 of these tests, the so-called triple positive people, are at a higher risk. So let's start by talking about patients with lupus who are positive for these antibodies, persistently positive, and have suffered a thrombosis. So these are people with a definite diagnosis of thrombotic antiphospholipid syndrome. All the evidence says that for these people, the treatment is anticoagulation. Steroids, immunosuppression, and so on are not proven to help these patients, and what you're aiming to do is prevent any further thrombosis from occurring. The evidence base is for long-term anticoagulation, and there is very little evidence suggesting that it's okay to stop anticoagulation. The most recent European EULAR guidelines suggest that there's a difference between provoked and non-provoked thromboses. So in other words, if there was a very good reason for the thrombosis, it may be possible to stop the anticoagulation. But if the thrombosis occurred and there wasn't a very good reason for it, long-term anticoagulation is the norm. So in a nutshell, if you have a patient with SLE and antiphospholipid antibodies and they have a thrombosis, the treatment is long-term anticoagulation, typically with vitamin K antagonists. There has been some recent literature about the use of the direct oral anticoagulants such as rivaroxaban, but the trials have not been favourable so far and they haven't really taken over from the vitamin K antagonists. So what about the patients who have the antiphospholipid syndrome, but they don't have thrombosis, they have pregnancy problems? So there is a subset of patients with this syndrome who have pregnancy loss, but they never have any thrombosis between the pregnancies. In these cases, the management of future pregnancies is with heparin plus low-dose aspirin throughout the pregnancy, and this leads to a live birth rate of 70% or more. And remember, the management is just the same whether the patients have lupus or don't have lupus. A patient with lupus and the antiphospholipid syndrome is managed just the same as a patient with antiphospholipid syndrome who doesn't have lupus, a patient with primary antiphospholipid syndrome. The things we do to prevent thrombosis or pregnancy loss are the same in both of those groups. Some people have argued for the use of hydroxychloroquine in the antiphospholipid syndrome, and as you know, many patients with lupus are on hydroxychloroquine anyway. It's possible that the hydroxychloroquine may help symptoms such as tiredness and joint pain, but there isn't any very good evidence that they prevent thrombosis. They cannot take the place of anticoagulants. So now I'm going to turn to patients with lupus who are found to have positive antibodies, but they haven't actually had a thrombosis. So in other words, they're at risk of a thrombosis, but they haven't actually had a thrombosis. So what are we going to do with those patients? This is called primary prevention, to prevent the first event from happening. Now remember, you don't necessarily have to treat all of those patients. As I mentioned, about 5% even of the healthy population will be positive for one or other of anticardiolipin, anti-beta-2-glycoprotein 1, or the lupus anticoagulant. And nothing will happen to them. So some people have what you might call false positives, antibodies which aren't going to cause any harm. Therefore, it would be excessive to treat everybody who had been found to have antiphospholipid antibodies with warfarin or aspirin. The question is, which people should we be treating? To work this out, you have to do a kind of risk calculation. You have to work out what all the risk factors for thrombosis in that person are. And that's not just the antiphospholipid antibodies. There may be things, for example, like factor V Leiden or activated protein C resistance, or being a heavy smoker. So take into account all the things that might affect that person's risk of thrombosis before you decide what to do. As for the antiphospholipid antibodies themselves, there are some features you need to take into account there as well. People who have high levels of IgG antibodies are more at risk than those with high levels of IgM antibodies. People who are double or triple positive are more at risk than those who are single positive. So think about those things as well. So let's suppose we have a patient who just has antiphospholipid antibodies and no other risk factors for thrombosis, and we found them to have lupus. What should we do with that patient? In such a person, there is no strong reason or evidence base to give anticoagulation, and most of those patients do not get treated with anticoagulation. But what about aspirin? Aspirin has much fewer side effects than anticoagulation. Maybe we could give aspirin to those patients. Now, in fact, Laurent Arnaud in France has done some very good meta-analyses of the literature on use of aspirin. In fact, there's only really one RCT on use of aspirin for primary prevention, which was done by Doric Erkin in the United States on a relatively small number of patients and did not show any protective effect in primary prophylaxis. Laurent Arnaud, though, reviewed 11 studies of observation to see if aspirin worked, and then did a further paper where he looked at 5 of those studies and got the patient-level data so that it was possible to allow for all thrombotic risk factors in those patients. And what he found was that there was some evidence in that second paper that aspirin was protective against the first thrombosis. I think what this comes down to is that in patients who have a high risk profile, such as triple positivity, it may be worth treating them with aspirin to prevent the first thrombosis. So remember, these are not people with antiphospholipid syndrome. As soon as they would have had a first thrombosis, anticoagulation is the way to go. These are people who've never had a thrombosis, but they have antibodies. Aspirin in the high risk profile patients. And finally, what about a patient with SLE who has positive antibodies, who has never had a thrombosis, but you're worried that they might have a pregnancy loss? So if they've had only healthy pregnancies before, it's unlikely that the antiphospholipid antibodies are going to cause a problem. If they've never been pregnant before, it's a tricky situation. There isn't really any good evidence for the use of heparin and aspirin, and this is often a very individual management choice involving the doctor and the patient together. Some of the patients might be offered aspirin, and a few might be offered heparin and aspirin, But in general, you need to be managing these cases with a specialist obstetrician who has some expertise in the case. There is no standard protocol saying those patients should be treated with heparin and aspirin. So my take-home messages are these. Many patients with SLE may have positive antiphospholipid antibodies, but they do not all have antiphospholipid syndrome. In order to have the syndrome, you must have suffered either a vascular thrombosis or a pregnancy morbidity. The people who actually have the syndrome are treated just the same whether they have lupus or not. Anticoagulation for thrombotic APS, heparin and low-dose aspirin in pregnancy for obstetric APS. The people who do not have the syndrome, they just have antibodies, but they haven't had any clinical features of APS. There is some evidence for aspirin to prevent the first thrombosis in high-risk patients. There is no good evidence that heparin and aspirin should be used in all patients of this type who have pregnancy, but it could be an individual decision that you make with the obstetrician involved. Thank you for listening.